Thank you so much, Professor Marwaz. Actually, the honor is mine, and I am lucky enough to be part of ACRA, and you have been always very kind to me and my colleagues. So definitely, I'm trying to do something for the people of my country and especially of my town, being the first ever cardiac electrophysiologist in that area. So after the extensive talk and very difficult talk by Dr. Galia, this talk is going to be very a simple one, and I have tried to make it as simple as possible, just trying to deliver the important essential points that we must know when we are going to use SGLT2 inhibitors in our daily practice in patients with heart failure. So what are the SGLT2 inhibitors? So this is the nephron, a structural cartoonated diagram, and we all know that the 90% of our sodium and glucose, they get reabsorbed by the proximal convoluted tubule. I do not know whether you can see my arrow or not. If it will be very easy if you can see. So these are the proximal
We see
tubules.
your arrow. We can see your arrow.
Thank you. So these are the convoluted tubules, and we know the 90% reabsorption of sodium glucose happen here. And we have here receptors called SGLT2 receptors. So the idea is if you block these receptors, this will prevent the reabsorption of glucose from these tubules back to the blood, and that glucose will travel along the nephron and will be thrown out of the body. This will result in the lower glycemic index. So this is why the SGLT2 inhibitors are very important in diabetes. But what about the patient's heart failure? One thing that we should remember that diabetes and heart failure, they share the same pathophysiological features. For example, both of them can lead to insulin resistance, and both of them lead to endothelial dysfunction. The other thing that we should remember regarding the mechanistic effects of these inhibitors are that they have, number one, the diuretic effects, as I have already shown you, and then number two is the metabolic effects. So because of the diuretic effects, you have loss of sodium in the urine, and because of this diuretic effect, you have also loss of glucose in the urine, which both are better for the patients in diabetes, but also in patients with heart failure only, because we don't want to reabsorb more and more sodium in the body in a patient with heart failure. The other thing is increased glucagon and increased ketone bodies. Now, please remember this thing, increased ketone bodies, and I will discuss this thing in another slide, where we have to remember this metabolic effects of increased production of ketone bodies. And then number third is the cardiovascular benefit of these inhibitors are largely independent of glucose level, and we will discuss the trials which have shown this thing. So let us come towards the cardioprotective side of SGLT2 inhibitors. This is an extensive diagram, but I will try to make it simple for you. So we have on our right side of screen the natriuresis limb, and on our left side we have these glycosuria limb. So let's move in this direction on the left side of the screen. When you have glycosuria, you have negative caloric balance, which results in decrease in the fat mass. That is, epicardial fat will be less, you will have more contractility, and all these phenomena result in the cardiac protection. Secondly, you have more glucose in the urine, you have less glucose in the blood, so your HbA1c level will go down with the passage of time. Less glucose in the blood, less inflammation, less glucose toxicity, again you have protection. Increased uricosurium, decreased plasma uric acid, less incidence of atherosclerosis, again you have cardiac protection. So these are only the three mechanisms which are shown in this diagram, just to make you remember that how glycosuria is beneficial for heart, not only for diabetes control. Secondly, about the natriuresis. So when you have more sodium in the urine and less sodium in the blood, you will have decreased blood pressure. This will lead to a decrease in the arterial stiffness, and obviously this is going to be very cardiorenoprotective. The other thing, the tubular feedback mechanism. So when you have natriuresis, there is constriction of the afferent arterioles. And this results to decrease in the hyperfiltration through the glomeruli. And again, you have more renoprotective benefit of these inhibitors. More sodium in the urine, less plasma volume, less myocardial stretch, less incidence of arrhythmias. So now you are also getting not only cardio protection mechanistically, also electrically. You will have less incidence of ventricular arrhythmias. And again, these things lead to cardiac and renal protection. So this is just a nutshell. There are many other effects also. We are not going to go through it. Empiric outcome, canvas trial, credence, declaratimi, vertis. These are some of the trials which were done in patients who had diabetes mellitus. So initially they found the role in patients who had diabetes to lower the HbA1c level, and they have found very beneficial effects in the diabetic population. This is a meta-analysis which was published in the Lancet, and the trials that I have just named. This is a diagram from the meta-analysis, and you can see here, I will just go through the punchline. It results in the heart failure, reduction in the heart failure hospitalization by 31% in patients with and without recognized atherosclerotic disease, and in patients with and without a history of heart failure. So whether you have heart failure and you do not have a heart failure, there was a risk reduction in the heart failure by 31%, which is a great percentage. And here comes our favorite, dapagliflozin, Phf Trial. And they used this drug in patients with or without diabetes mellitus having heart failure with reduced ejection fraction, that is EF less than 40, equal to or less than 40%. And what they showed us, a reduction in the cardiovascular deaths and the rate of hospitalization. Similarly, empagliflozin, this trial include patients who have more severe heart failure symptoms. Although the EF was the same, cut off 40% or less than 40%, but the BNP levels were higher as compared to the DAPA groups, the last trial that we discussed. And again, with or without diabetes mellitus. And this also showed the cardiovascular death in patients despite having diabetes or not having diabetes. Now that was beautiful thing, that we can use these drugs not only in diabetes but also without diabetes having cardiovascular morbidities. This is a beautiful position paper in which what they did, so we see all these patients in our clinic on daily basis. Or do not they have AFib, have CKD, or they do not CKD. They took the considerations of these 4 parameters and they divided the groups into multiple profiles, and here are a bunch of them. I'm not going into the detail, but the important thing in this diagram is whichever profile you choose. For example, let me take the heart rate of 60 to 70. So if the heart rate is less than 60, there is no contraindication for SGLT2 inhibitor. If the heart rate is more than 70, there is no contraindication for SGLT2 inhibitor. So you can think about reducing the dose of beta blockers. You can think about whether we should give ivabradine or not give ivabradine, but you always have a drug in your pocket, SGLT2 inhibitor, that you can give to your patient and get benefit from this drug. Similarly, regarding the blood pressure, whatever is the blood pressure, there is always a margin for SGLT2. So the SGLT2 inhibitor is always on the top choice that you can always write on your prescription pad for your patients. This is a very good thing for your patient. So in case of patients having heart failure with reduced ejection fraction, dapagliflozin, or these are the ESC guidelines. They are recommended for the heart failure with reduced, which reduce the risk of hospitalization SGLT2 inhibitors. They are now the fourth pillar of the heart failure management protocol. Now, what about the primary prevention? So we know we have patients who have heart failure. What about the patient at high risk of cardiovascular disease? So if you have a patient who has diabetes and you assess the cardiovascular disease and he comes out to be at high risk, you can safely use it. In fact, this is not about even about safety. This is class 1. This is a priority. Diabetes, for sure, your patient has diabetes, your patient has heart failure with reduced ejection fraction. It is going to work on both sides. Definitely class 1 indication. This is a trial, Solis Phf Trial, and they have used this sotagliflozin drug in patients with diabetes and heart failure patients. And the beauty about this drug, sotagliflozin, is that this patient has action not only and in the gut, this septum does is it reabsorbs glucose from the gut. So this drug, it inhibits the glucose reabsorption in the nephrons as well as it inhibits the glucose reabsorption from the gut. So you will have less glucose in your blood. And this trial showed that the worsening heart failure was reduced even if you start this therapy shortly or after the discharge of the patient. Reduced cardiovascular mortality, reduced hospitalization rate. Very effective drug. Now this is always an Achilles of our heart failure patients whenever we talk about the heart failure with preserved ejection fraction. But this is the good news for us because they have researched and used empagliflozin in patients with preserved ejection fraction. And I will just share the conclusion here that the EMPA reduced the combined risk of cardiovascular death or hospitalization for heart failure patients with heart failure and a preserved ejection fraction. So if the EF is more than 50, they have found that they have reduced the risk of this is a very good thing. But there was one limitation that as the EF goes higher, EF is more than 55, 60, these effects, you are not getting these effects. So there is a range of the EF in which you will get these benefits. There are trials which are going on and we will see what happens to them. We will see the results in the coming year. Regarding about talking about the clinical aspects, when you're describing this, you must know the contraindications. You must know if the history has patient has any history of previous allergy. Limited data is available if the GFR is less than 20 ml per minute. Do not give in pregnancy lactation. Try to avoid if the patient BP is less than 95 systolic or whatever is the BP, but the patient is symptomatic due to hypertension. You have to avoid it because we know there is natriuresis, there is glucose urea. This will lead to decreased plasma volume and you may exacerbate the hypotension if you are giving SGLT2 inhibitors in that profile in patients with those profiles. Caution, type 1 diabetes mellitus. So type 1 diabetes mellitus patients, they have the increased tendency to develop diabetic ketoacidosis, ketone bodies. So you remember the initial slide when I requested you to remember the increased ketone body genesis. This is one of the effects of SGLT2 inhibitor, that it increases the production of ketone bodies in our body. So in patients with type 1 diabetes mellitus who are always at risk of diabetic ketoacidosis, we should not give these drugs. If the patient has genetic urinary infection, for example, specifically fungal infection, you must avoid it. Be aware of the interaction with other anti-diabetic drugs and diuretics. Why diuretics? Because loop diuretic, they are going to decrease the plasma volume. SGLT2 inhibitor, they are going to decrease the plasma volume. Both of them will lead to hypotension. So you have to titrate the dose, use with caution. We have to use diuretics, of course, but we have to use them with caution. Make a balance out of them. Whenever you're using these things, take a look at the HbA1c level, take a look at and look for the predisposing factors for ketoacidosis. The patient is not getting very much vomiting, fever, and things like that. So we have to educate the patient whenever you are having something imbalance. Please come back to us so that we can take a look. Patient education is very important. I remember a case. Patient was referred to me for the heart failure treatment, and he was having 2 plus glucose samples in the urine. So SGLT2 inhibitor was started. So after 1 month, patient came back and told me, doctor, you have started this drug. Previously, I had only 2 plus glucose in the urine sample, but now I'm getting 3 plus glucose in the urine sample. So my thing is worsening, my diabetes is worsening. So of course, when you have more glucose in the urine, you will get an increase in the plus of the urine sample. So you have to educate them that this is nothing to get worried about. Just be conscious about your HbA1c level. So take home message for all my colleagues, my seniors, respected. We have to welcome this very beautiful drug, mechanistic effects, taking control of both the heart failure side and both the diabetes side. They have cardioprotective mechanisms, they have renoprotective mechanisms, and primary prevention type 2 diabetes mellitus use these drugs. Dapagliflozin, canagliflozin, EMPA, ertogul, and sotagliflozin are recommended. Trials are available for heart failure with reduced ejection fraction for dapagliflozin and empagliflozin. And if the patient has diabetes, use DAPA, EMPA, and sotagliflozin. Regarding the mid-range EF and regarding the preserved EF, there are more trials coming on. There is more work, and we hope that we are going to see some breakthrough trials regarding in this range, because we need some drugs to work efficiently in this profile of patient. We always feel helpless in preserved ejection fraction patients. Thank you so much for your attention. I will hand over to Professor Marbat.
Thank you very much, Haseeb.